Heart blocks. You either love them or you hate them. That's exactly what we're going to be talking about today in our ECG concept series. We're going to be talking about all the different kinds of heart blocks. Let's get started. So we're going to begin with heart block rhythm concepts. What specifically do we need to know about these? Well, the big thing is that heart blocks are blocks in the conduction system. They either can be a delayed block, a progressive delay, a prolonged wave, or they can even have a drop wave. So the big thing here is that blocks can take place in one of two places. They can take place up here in the atrioventricular area, meaning that it's an AV block, or they can take place a little bit lower down in the bundle branch area, making them BB blocks. So what's an easy way to remember all of these different kind of heart blocks? Well, we have the mnemonic TGIF. So let's break each one of these down. The big key when it comes to heart blocks is we're looking at issues with the PR interval. So with the first degree heart block, our T stands for too long, meaning that the PRI is going to be too long. It's going to be outside of our normal values. With our second degree type 1, the PRI is getting, that's our G, longer, until eventually we have a dropped QRS beat. The second degree type 2 means that the PRI is going to be identical, that's our I, when it is present. So anytime we have a P wave that has a QRS complex behind it, that PRI is going to be identical every single time. And then lastly, we have our third degree heart block. The PRI is hard to figure out, that's our F, right? The atria and the ventricle are not communicating with each other, so it's going to be really hard for us to identify a true PRI interval that's consistent throughout the entire strip. So starting with our first degree heart block, this is characterized by that prolonged PR interval on our ECG. In this condition, every electrical impulse from the atria is conducted to the ventricles, but that conduction takes a little bit longer, right? There's a slower conduction leading to that elongated PR interval. So if we were taking a look at this ECG strip, you're going to see we have a P wave here, but look how long that delay is in between our atrial depolarization and our ventricular depolarization. Otherwise, everything's normal here. You're not going to see any drop beats. There's going to be no irregularities in this rhythm. It just happens to be that we have this elongated PR interval. With this kind of rhythm, it's the more mildest form of our heart blocks. Many individuals don't even know that they have it. They can be asymptomatic, and usually it's not going to require any kind of treatment. What's interesting to note is that this can be seen in even healthy individuals, including well-trained athletes, where this might actually be a normal physiological adaptation. So taking a look at rhythm identification, the rhythm is going to usually be regular, right? You're going to be able to march everything out. Everything's going to fall in the correct places. The heart rate usually is going to fall between 60 to 100 beats per minute, and the P wave is going to be normal. It's going to be upright. It's going to be before each QRS complex. The big key here, like we talked about before, is that PR interval is going to be greater than 0.2 seconds. It's going to be outside of our normal range. However, the good thing is that the QRS complex is going to be narrow and normal, right? This is a nice tight QRS complex. So we know that it is, a good rhythm. We're not seeing any of these big, ugly, wide QRS complexes. We just happen to have a little bit of an issue with the delay in the conduction. And then like we talked about before, there's going to be no abnormal beats. Just like with bundle branch blocks, this is another rhythm where you're going to have to identify the underlying rhythm. So in this case, because everything appears to be normal, we could say that this is a normal sinus rhythm with a first degree block. So what are some of the causes that you might see? Well, there could be an intrinsic AV node disease. Like we talked about, the AV node is that node that prevents that information from getting down to the ventricles. It gives it a little bit of time for that atria to really contract and get all that blood into those ventricles as possible before the ventricles ultimately do their contraction. We could see an enhanced vagal tone, maybe even acute MI could be taking place. Electrolyte imbalances are huge. Anytime you see any kind of irregularity when it comes to ECGs, check your electrolytes, see what's going on. You could have myocarditis, you could have CAD, or you could even see some antiarrhythmic medications that could lead to this delayed process. When it comes to signs and symptoms, typically these individuals are going to be asymptomatic. They're usually discovered accidentally on an ECG, and it could be an indicator of some kind of underlying heart disease that's taking place or electrolyte imbalances, but generally it doesn't really have a whole lot of symptoms attached to it. And because of that, treatment's not necessarily required in these individuals unless they become symptomatic. Next up, we have second-degree heart block type 1. This is the first type of heart block that you are not going to have to identify the underlying rhythm. So what is a second-degree heart block type 1? Well, it's also known as a winky block or a Mobitz type 1, and it's characterized by a progressive lengthening of our PR intervals followed by a dropped beat. So if you look here, we have a short PR interval, then it gets a little bit longer, and then it gets a little bit longer, and then right here we have a P wave with nothing behind it, right? We get ghosted, right? Our QRS just gave up. So that's what's happening with our second degree heart blocks, is just gonna get longer, longer, longer drop, and that is our second degree type 1. So with ECG rhythm identification, the atria is typically going to be regular and the ventricular rhythm is going to be irregular because of that dropped beat. The heart rate, really depends. It can be normal, it can be slow, depending on what's going on with this particular delay. The P wave is going to be present, it's going to be upright, it's going to definitely be there. And of course, our PR interval is going to get longer, longer, longer before we ultimately see a drop. And then with our QRS complex, narrow and normal typically is what it's going to be. As you can see here, it's nice and tight. It's a nice narrow normal rhythm until ultimately you have this drop take place and it's not even there at all. And then lastly, abnormal beats. Well, I just put in that we have a dropped QRS at this point. That's a little abnormal, right? Because we would typically see a QRS right behind this drop beat and right behind this drop beat. So yes, that dropped QRS is going to be abnormal on this rhythm. So what are some of the causes behind this? There's certain medications like digoxin, calcium channel blockers, even beta blockers and antiarrhythmics that can lead into this more progressive block. There could be an inflammatory or metabolic vascular disorder that's taking place. You could see an acute MI, even post-cardiac procedures, as well as surgeries. More specifically, cardiac ablations. This tends to be one of the common rhythms if somebody was to go into an abnormal rhythm with having those kinds of procedures. And then we have valvular disease, OSA, which is obstructive sleep apnea, or even alcohol poisoning can lead to this. When it comes to our signs and symptoms, typically they are going to be asymptomatic. If they do start to experience symptoms, it's most likely going to be palpitations or lightheadedness, and that's again very rare in these kinds of rhythms. And when it comes to treatment, we really don't treat this rhythm unless they become symptomatic. If they do become symptomatic, then we are going to follow our ACLS algorithms. We might be giving them atropine in this particular situation if the heart rate's too slow. And if the heart rate's too slow and it's not responding to atropine, we may even be looking at transcutaneous pacing until a transvenous pacer is placed. Next up, we have a second degree heart block type 2, and this is known as a Mobitz 2, and it's characterized by a sudden and unexpected failure of some atrial electrical impulses to conduct down into our ventricles without prior lengthening or PR intervals like we see with type 1. So in this case, remember the I stands for identical. So our PR interval is going to be identical when it is present. So if I was to measure this PR interval with this PR interval with this PR interval with this one, you're going to find that they are going to be identical. But what we have here is we have a P wave and nothing behind it. P wave, nothing behind it. P wave, nothing behind it, so on and so forth, all the way down. So that's how you can tell that you have a second degree type 2, is that now my PR interval looks exactly the same every single time when I have a QRS complex there. However, I do have some drop beats behind some P waves. So that is the big difference between type 1 and type 2. So what are we going to see here when it comes to rhythm identification? Well, again, the atria should still be regular and our ventricular rhythm is going to be irregular due to those drop beats. The heart rate is going to be dependent on what's going on with the heart rhythm. It could be normal or it could be slow. The P wave is going to be present and upright. As we know, whenever we have them, they look good with these second degree type 2s. The PR interval, like we talked about before, is going to be normal and constant when a QRS complex is there. And what's interesting about the QRS complex is depending on where the block is taking place, we could see one of two things. We could see narrow and normal QRS complexes, or we can see big, wide, and ugly QRS complexes. In this case, we have nice, narrow, and normal complexes, so most likely it's taking place somewhere up there in that atrioventricular node. And then lastly, when it comes to abnormal beats, of course, we're going to see those drop QRS complexes. So the causes here either are really going to follow the second-degree heart block type 1, but the big difference is that you're going to see post-TAVR. So TAVR is a specific procedure when it comes to replacing a valve inside the heart. In this case, second-degree heart block type 2 is very common in these individuals, and it's much, working as a CVICU nurse in the past, you really have to keep a very good eye on these TAVR patients because they tend to go in these kinds of rhythms, and they're easy to reverse as long as we can identify it early. When it comes to signs and symptoms, they usually are more symptomatic than we see with our previous heart blocks. It can lead to a sudden drop in heart rate. You're going to see potentially even syncope, fatigue, chest pain, palpitations taking place. They really do tend to be more symptomatic. And because they're more symptomatic, that means we're going to be treating these individuals more aggressively. So again, transcutaneous pacing until we get that transvenous pacing available to us. They may even be put on medications like dobutamine, dopamine, or epinephrine, which are beta-adrenergic agonists if they're unstable, depending on how this particular person presents. Atropine in this situation is going to be really ineffective. There's no point if we have a slower heart rate to give these individuals atropine because it's not going to really do a whole lot. And of course, we want to treat any reversible causes. In this case, if it was a TAVR situation, then they might have to go back in and replace or whatever it looks like for that individual. Now let's talk about our last heart block, which is a third-degree heart block, also known as a complete heart block. And this is characterized by the complete disassociation of our atrial and our ventricular contractions. This occurs because the electrical impulses generated by our atria do not pass into our ventricles. On an electrocardiogram, you're going to observe that the P waves that occur at a regular rate occur independently of our QRS complexes, which also appear to be regular. So both our atria and our ventricle are regular, but they are not talking to each other. So you might be questioning, why is this heart rhythm lethal? Well, a third-degree heart block is lethal because the ventricles rely on their backup pacemaker systems known as their Purkinje fibers, which are primarily slower and less reliable than our normal sinus node. This can ultimately lead into reduced cardiac output, leading to severe symptoms if not adequately treated. And the risk of asystole increases greatly when it comes to this rhythm because it's relying on those escape rhythms in order to make the ventricles contract. So what are we looking at when it comes to rhythm identification? Well, we have the atria and the ventricle. They're going to be regular but independent of themselves. If I was to measure out my atria on my strip, they're going to fall in the exact same place every single time. And our ventricles are going to do the same thing. They're also going to fall in the exact same place every single time, but they're not going to be dependent on each other. When it comes to our heart rate, our atria is going to be between 60 to 100 beats per minute, and our ventricles are going to be between 20 and 40 beats per minute. Remember, we're relying on those Purkinje fibers that usually beat between 20 to 40 beats per minute. Our P waves are going to be upright and normal typically, but you're not going to see a PR interval in this case because we don't have any correspondence between the atria and the ventricles. The QRS complex, again, can be narrow, normal, or it could be big, wide, and ugly. Most of the time it's going to be big, wide, and ugly because it's only receiving information down there from the Purkinje fibers. And then lastly, we're going to see abnormal beats. Not really, right? This entire thing is an abnormal beat. So in this particular case, there's really not going to be any kind of abnormalities when it comes to this rhythm. There are a ton of different causes when it comes to third-degree heart blocks. There could be certain medications like we talked about before with DIG, calcium channel blockers, beta blockers, and antiarrhythmics. Again, we can see that inflammatory or metabolic vascular diseases, not very common, but it can happen with post-cardiac procedures and surgeries. There could be like a hypoxia, acidosis, hyperkalemia situation taking place. So we definitely want to make sure we're checking our H's and our T's. And then lastly, there could be like a valvular disease or some kind of hypothyroidism that has been left untreated that could ultimately lead to this kind of rhythm. So with third-degree heart block signs and symptoms, you're going to see significant symptoms due to that disassociation between our atria and our ventricles. So the symptoms are going to be much more severe. You're going to see very severe fatigue, dizziness, syncope, and sometimes you're even going to hear people say, I feel like I'm dying, because it's just their heart is so erratic because they're not talking to each other. It almost feels like they're dying. You're going to hear people say that. So when it comes to treatment of our third-degree heart blocks, we're going to follow the ACLS algorithm when it comes to bradycardias. So atropine is an option to provide to these individuals to see if that will help turn it around, but I can almost guarantee you that they're going to end up with some kind of transvenous pacemaker. It's very rare that they don't. 9 times out of 10, they usually end up with a transvenous pacemaker, but usually before that, we're placing those transcutaneous pacemakers, which is the pads that sit on top of the chest. So it's going to be very uncomfortable for the individual. Make sure that they have a lot of pain medication on board because we want to make sure that they are calm and that they are not experiencing too much pain. And then, of course, we can even consider things like dopamine and epinephrine infusions if all else fails. Taking a look at our next practice question, is our rhythm regular or irregular? Well, if I was to march this out, you're going to see that this happens to be a regular rhythm. So we can definitely say this is irregular. What is our heart rate? Let's count our QRS complexes. We have 1, 2, 3, 4, 5, 6, 7, 8, and 9. So we have approximately 90 beats per minute. Do we have P waves? We absolutely do, right? We have a P wave here, 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 so on and so forth. So they are definitely present. Well, what's happening with these P waves? If I was to measure this out, you can see that this PR interval is very long, right? It's much longer than what we saw originally with our previous practice question. So this is approximately 0.28 seconds. Our QRS complex, looking at it, it does appear to be narrow and normal. So I would say it's less than 0.12 seconds. And do I have any abnormal beats? I absolutely do not. So what do I have here? I have what looks to be a regular rhythm, right? I have a regular rhythm, 90 beats per minute. P waves are present. I have a nice narrow and normal QRS complex. So I look like I'm looking at a normal sinus rhythm, but the only difference here is I have this very long PR interval. So if I have a regular rhythm with a long PR interval, which heart block do I have? You got it. I have a first-degree heart block. In this case, you want to identify the underlying rhythm. So we would call this a normal sinus rhythm with a first-degree heart block. So what kind of rhythm do we have here? So if I was to measure out my QRS complexes, oh, look at that. I'm missing a QRS complex here. So I know I'm dealing with some kind of block. And if I was measured out, this would be regular. So this case, I have atrial, which is regular, and then my ventricular is irregular. So what is my heart rate? Let's count our QRS complexes that we have here. So I've got 1, 2, 3, 4, 5, 6. So we get approximately 60 beats per minute with this rhythm. Do I have P waves? I absolutely do. I have a P wave here, P wave here, P wave here, P wave here. So they are present in this situation. But when I'm looking at my PR interval, I'm noticing some kind of pattern here. So right here, it's a little short, and then it gets a little longer, then it gets a little longer, and then I have a P wave and nothing behind it, right? We got ghosted. And then it goes back to that same pattern. It's a little short, gets a little bit longer, and then again, I have a drop. So we have a PR interval that is getting longer as we move down our 6-second strip. What about our QRS complex? If I'm looking at my QRS complex, it is definitely narrow and normal. It's nice and tight here. So I would definitely say it's less than 0.12 seconds. And do I have any abnormal beats? I do. I have a drop QRS, right? I'm missing some beats here. So taking a look at this, I have my atria, my ventricle. Atria are regular, ventricles are irregular. My P waves are present, but this is the big thing. That PR interval is the big thing. I'm getting a longer PR interval until eventually I have a drop. What heart block is characterized by that? You are absolutely correct. The correct answer for this is going to be a second-degree heart block, type 1. So what do we have here? We have a heart rhythm. We see, taking a look at our QRS complexes, they're not really regular when it comes to QRS, but if I was to measure out my P to P interval here, I do have atria that are correct. So my atria are regular and my ventricles are irregular. What's my heart rate? Well, in this situation, my heart's going to be a little bit slower than I can see, right? 1, 2, 3, 4, 5. So I have a ventricular heart rate of approximately 50 beats per minute. It's a little slow. Do I have P waves? I absolutely do. They are present. But what's interesting about these P waves, let's take a look at our PR intervals. So here, when I measured this one and compare it to this one, compare to this one, compare to this one, compare to this one, they are all identical, right? So they're identical when they are present. And what about my QRS complexes? These are very different from what we've been seeing before, right? These are huge. These are big, wide, ugly QRS complexes. So these are definitely going to be greater than 0.12 seconds. And do I have any abnormal beats? I absolutely do, right? I have a P wave with nothing behind it here, a P wave and nothing behind it here, P wave, nothing behind it, so on and so forth all the way down. So I definitely have some dropped QRS complexes. So I know I'm dealing with a heart block. What makes heart blocks special is we're looking at the PR interval. So what's happening with our PR interval that we can see here? Well, the PR interval is identical when it is present. Which heart block is identical when it is present? You are absolutely correct. It is a secondary heart block type 2. Let's take a look at our last practice question. So when we're looking at our rhythm, is it regular or irregular? If I'm looking at my P to P interval, it looks regular here, right? I can march it out. And if I look at my R to R interval, they also look regular. But the problem is there's no organization between them. So while they are all regular, they are regular independently of each other, right? So do I have a heart rate? I do. I can look at both, right? I can count my P waves. So I have 1, 2, 3, 4, 5, 6, 7, 8. I have approximately an atrial heart rate of 80 beats per minute. And then when it comes to my ventricular heart rate, I have 1, 2, 3. I have approximately 30 beats per minute, right? So my ventricular heart rate is very slow, and my atrial heart rate seems to be within normal. Do I have P waves? I do, right? I can identify my P waves as I move down this strip, so they are definitely present. But do I have a PR interval? Not really, right? I can't really identify any consistency when it comes to the PR interval because this one's really, really long. Then if you move a little bit down, this one's behind the QRS complex. This one's even longer, right? We have nothing behind it. This one's hugging. This one, again, nothing behind it. This one's longer than any of these, right? It just doesn't make any sense. Do I have QRS complexes? I do. And in this particular case, they appear to be narrow and normal. So this is going to be less than 0.12 seconds. And do I have any abnormal beats? Not really. The biggest key here when it comes to this particular kind of rhythm is the fact that I have an atrial and a ventricular rhythm that are both working appropriately. They're just not speaking to each other. So anytime we see this chaotic kind of rhythm, we're most likely dealing with a third-degree heart block. I hope that this video is helpful in understanding everything you're going to need to know when it comes to your heart blocks. As always, if you have any questions, make sure that you leave them down below. I love answering your questions. Head over to nursecheungstore.com. There's a ton of additional resources in order to help you ace those ECG concepts. And as always, I'm going to catch you in the next video. Bye!